Good morning, everyone. I'm K. Shruti, second year postgraduate from Andhra Medical College, Visakhapatnam. I'm here to present a paper on a clinical study on the role of OCT in Parkinson's disease. Financial disclosure, no conflict of interest. Coming to introduction, idiopathic Parkinson's disease is a common neurological disease characterized by selective loss of dopaminergic neurons in the nigrostriatal pathway, resulting in progressive motor and non-motor symptoms. Here, visual dysfunction is presented as decreased visual acuity, decreased color vision, contrast sensitivity, and motor perception. These visual defects may be due to loss of dopaminergic denervations of amacrine retinal cells, which is essential for light adaptation. Recently, there is a reduction in retinal nerve fiber layer thickness has been found in neurological diseases, which is normal of 101 plus or minus 10.13 microns. Aim of my study is to evaluate retinal structural changes in Parkinson's disease and to establish the role of OCT in Parkinson's disease. This is a prospective study conducted in Government Regional Eye Hospital. The sample is from Department of Neurology, Andhra Medical College, Visakhapatnam, from January 2023 to May 2023. Primary Parkinson's disease in the age more than 40 years of both sexes were included. Patients having prior history of optic neuropathy, maculopathy, glaucoma, high myopia, dense media opacities, age-related macular degeneration, peripheral vasospasm, sleep-related breathing disorders, ocular trauma, and ocular surgery were excluded. Detailed histories were taken and all the patients underwent ophthalmological testing, including visual acuity, color vision, slit lamp examination, intraocular pressure measurement, visual fields with automated perimetry, fundoscopy, and OCT. OCT was performed with Cirrus SD-OCT. The OCT imaging was performed with the patient's pupils dilated to obtain higher signal quality and discarded if signal strength was less than 8. Average temporal, nasal, inferior, superior quadrant, peripapillary, RNFL thickness were obtained from the OCT. Coming to results, most of the Parkinson patients are male, almost 72%. Age distribution, most of them come under 51 to 60 years, that is 39.3%, followed by 41 to 50 and 61 to 70 and 71 to 80. Coming to visual acuity, all are between 6.6 to 6.36, most of them in between 6.18 to 6.24. Color vision is abnormal in almost 25% of them. Coming to visual fields, most of them are unreliable, and in the compared reliable, 30% are having arcuate scotomas and 30% are having decreased superior field sensitivity. Coming to RNFL thickness, average RNFL thickness in Parkinson is 89.91 plus or minus 8.2 microns, significantly thin compared to normal. Compared RNFL thickness in normal versus Parkinson. IOP and slit lamp examination is within normal range. Color vision is abnormal in almost 25% and are inconsistent with RNFL thickness. OCT will reduce RNFL thickness in temporal quadrant of Parkinson's, followed by superior and inferior quadrants. Almost all the patients in our study are having normal mini mental state examination, so there is no cognitive decline. A study by Inselberg et al. And Mostius et al. Also found selective thinning of RNFL in the temporal quadrant, similar to our study. And these are other studies similar to my study. Conclusion, this study shows a significant decrease in RNFL thickness in temporal quadrant, followed by superior quadrant in Parkinson's disease. Further studies should be conducted with prospective long-term follow-up and investigations to elucidate data from a larger sample about retinal structural and functional changes in the course of disease. This helps us to know whether OCT can be used as prognostic marker for Parkinson's disease in future. These are my references. Thank you.
How did you choose the controls for measuring the RNFL thickness?
Normal RNFL according to journal site. I didn't take controls.
You didn't have other subjects.
No,
you just took it from literature.
Yes.
Okay.
You were comparing with the normative database.
Yes.
But all degenerative diseases going to give you a nerve fiber layer reduction.
Yes.
So it is not a diagnostic value, even if it is
Prognostic.
Yeah, even prognostics wise, you can't say just because it has come down to the 10%, you can't say your prognosis is bad. So we can't say like that. It's only an indicator that what is the activity is going on, how much is the degeneration going on. We can say is it going or not. That's the only thing we can say. We cannot say the complete prognosis or the visual prognosis as such.
Okay.
So So it's a degenerative disease, but affects mainly the afferent system or efferent system.
Difference.
So it's affecting the efferent system. Okay, so why the RNFL change is expected in this disease is first question that you should think. And if it is there, how is it useful? As sir was saying, it is primarily for the prognosis. So is it there is enough literature that tells that it can serve as a biomarker of the progression. So the study should be done for a longitudinal follow-up of these patients. A cross-sectional study without any controls may not carry much added knowledge to the existing data.